and let's go ahead and get started. Let me introduce myself. My name is Shawn Needham. I'm a pharmacist, graduated from the University of Washington in 1994. I own my own specialty compounding pharmacy in Moses Lake, along with my wonderful wife Janet. She's also a pharmacist, and we have been specializing in hormone replacement for 20 plus years, and we're kind of known as pharmacist experts in the field of hormones. And we have patients and providers we work with all over Washington, Idaho, and Oregon. So optimizing thyroid replacement, hormone replacement, there's going to be a little bit of a paradigm shift you might have today, and hopefully you have some aha moments. For most of this stuff I did not learn in pharmacy school, and conventional thinking is, in traditional medical practices, it's a little bit different than that, so bear with me. Okay, we got to go into some definitions first. So, and I'm not sure if I do have it in a slide maybe later. So, the difference between synthetic, natural, and bioidentical. This is really, really important. So let's just use some common things that we prescribe possibly every day, or at least we see every day, and maybe should or shouldn't prescribe. Is Premarin natural? Where does Premarin come from? Premarin stands for pregnant mare's urine. It is isolated from pregnant mares and concentrated estrogen, because their urine is concentrated estrogen. Is it natural? Yes. Is it natural to humans? No. Okay, so there's at least 19 different estrogens in Premarin. Estrone is in there, estradiol is in there, which humans do have. But Eclin is in there also, which humans do not have. There will never ever be a generic Premarin. That's why there's not a generic now, even though it came out in 1947. And why? Because we don't know all what's in it. So, in my opinion of Premarin is this. Premarin is analogous, in my opinion, to prescribing Premarin is analogous to prescribing beef and pork insulin. We don't prescribe beef and pork insulin anymore, do we? Why don't we? We have human insulin. So think about that when you see somebody on Premarin. We have other options, okay? And natural, so synthetic. Synthetic is synthesized in a laboratory, right? So is that necessarily bad? One of the most common things we deal with synthetic hormones is levothyroxine. We get questions from patients, well, is this natural? Well, it's synthetic. Levothyroxine is T4, also known as T4, thyroid 4. It is literally L-tyrosine, an amino acid, and 4 iodine molecules. That's why it's called T4, okay? It is synthesized in a laboratory, but it is bioidentical. Let's think back to Latin terms. Bioidentical, what does that mean? Bio meaning life, identical to what's in our bodies, okay? So yes, levothyroxine is synthetic, but it is bioidentical to what's in our bodies. That's what's important. That's why it's important to know these different terms. When we think about hormone synthesis in general, we need to think about different hierarchies and where hormones are made. So, and you'll catch me doing it, and I do it all the time because it's really easy, and we do it in conventional medical practice all the time. We lump hormones, and you've already heard me say it a bunch of times today. We lump hormones all in the same category, right? But let's just think about what a hormone is, okay? What do we think of when we hear all the time when a woman's had breast cancer, oh, you gotta stay away from hormones. Okay, well, let's remember what a hormone is. A hormone is literally a messenger. Insulin is a hormone. I know that sounds really facetious, but I'm doing that because hormones are all created differently, okay? Levothyroxine is a hormone, liothyronine is a hormone. So we need to be able to differentiate between each individual hormone. Hormones are made, for the purpose of this discussion, we're going to talk about hormones being made in 3 different organs: adrenal glands, thyroid gland, and sex organs, so ovaries and testes. And remember this is very, very important. Those hormones follow a hierarchy. They are meant to work in symphony together. They all work together, okay? Think of it as this: adrenals, thyroid, sex hormones. Think of it in that hierarchy. Without the adrenal glands, our adrenal glands, size of a pea, they're right above our above adrenals, above our kidneys. They're very small. They produce hormones in response to stress. When I think of them, when you think of the adrenal glands, you think of adrenaline, right? That's where the name comes from. That's epinephrine, fight or flight hormone, okay? Also think of cortisol. Cortisol is more not so quick acting, but it is produced in the adrenal glands, and it should be produced in the adrenal glands in a diurnal variation. Highest in the morning, going down throughout the day, being lowest at night when we should be sleeping. If your adrenal glands aren't working, it trumps everything else. If you're not sleeping because your cortisol is too high at night, for whatever reason, it could be because you're up having hot flashes, it could be because you're just stressed too much at night, maybe you exercise too late, your diet's not good, all those things. If your adrenals aren't in balance, your thyroid won't be optimal, your sex hormones won't be optimal. Adrenals are very, very important, and sleep is very, very important with recovery of adrenals. The second one would be thyroid. That would be the second one as far in the hierarchy. Thyroid is very important. Remember, without adrenal glands, this is how important it is. Without our adrenal glands, we will die very soon. We can live without a thyroid, not super healthy, but you can replace it. And we can live without our sex hormones. Not as healthy, but we can live without them. So it's in that order when we balance hormones. Think about that. Okay, thyroid. So I talked a little about T4. It is just L-tyrosine and 4 iodine molecules, and T3 is L-tyrosine and 3 iodine molecules. I put in here it's the active form of thyroid. That's not as correct, as it's really just the more potent form of thyroid. So the most popular drug prescribed in 2016 was levothyroxine, also known as the brand name Synthroid, generics levothyroxine. It was patented in about the 1960s. It has to be converted into T3 in order to see the best results in our body, because that is a more potent form of thyroid. We'll go into some reasons why that doesn't always happen a little bit later, but T3 is very, very important. So, low thyroid symptoms, you might see some of these, look at some of these in your practice. Depression, weight gain, decreased libido, constipation, increased sensitivity to cold, fatigue, high cholesterol. I like to go over these because, have you guys ever heard of the term functional medicine? Maybe? It's kind of a new buzzword term, but I believe in treating the problem, not symptoms. Think about some way we treat symptoms. 45-year-old woman, she's got depression, she needs Prozac. 45-year-old woman, she's got high cholesterol, she needs Lipitor. Think about that. How many of your patients, middle-aged, female or male, might have depression, might have high cholesterol, and they're on 2 different drugs that cause side effects, and you've never checked their thyroid? That's a very, very important piece. Now, remember this also. This goes along, if you missed yesterday's presentation, this goes along with that presentation very well, is that low thyroid symptoms mimic low testosterone symptoms. So their symptoms mimic each other. So testosterone helps to lower cholesterol. Testosterone is a mood-elevating hormone. It's a feel-good hormone. Makes us feel better, increases libido. Think about testosterone also in those situations. They might not need those cholesterol medications or that medication for depression if their hormones are balanced. And why do we see it commonly in men that are in their 50s or women that are in their 40s when they start having decreased levels of hormones? Why do we see some of these symptoms? Because their hormone levels are going down. So think about balancing hormones before you think about prescribing a drug. Okay, commercially available thyroid. I talked about it a little bit. Synthroid, levothyroxine came out in the 1960s. Cytomel is liothyronine, T3. There's many generics available. What is the problem with T3? T3 has a very short half-life. 2 to 6 hours, depending on the patient. So that's one of the problems with T3 is that if you give it in the morning, at 7 o'clock in the morning, if you take it at 7 o'clock in the morning, it's going to wear off before noon. So either you have to dose it maybe BID or have a slow release formulation of T3. We'll get into that a little bit later. Arbor thyroid, are you guys familiar with arbor thyroid? Also, nature thyroid, same thing. It is porcine thyroid. What is porcine thyroid? Porcine comes from pork, okay? This is like Premarin, it really honestly is. I don't necessarily think it's bad because it's the only commercially available T4, T3 combination we have. So I think for a certain subset of patients that don't respond to levothyroxine, I think Armour thyroid is okay. What are some problems with Armour thyroid? It is literally ground up pig's thyroid. So it's kind of the same thing as when we talk about Premarin. We know there's a T4 and a T3 combination in there. 1 grain, which is 65 milligrams of porcine thyroid, it has 38 micrograms of T4 and 9 micrograms of T3. You can't vary that ratio. So if you give them 2 grains, the ratio doesn't change. They're going to get double the amount of T4 and double the amount of T3. So you can't change that ratio. That's one of the disadvantages. The other disadvantage is it comes from pigs. So it stinks, for one. And so another disadvantage is people that are, strict vegetarians, or Jewish. They don't want to have any kind of pork products. So that can be an issue. Another one of the issues is that it's getting more difficult to source. Porcine thyroid is grandfathered from the FDA. Before the FDA came into effect in 1938, there were porcine thyroids on the market in the 1890s, okay? Think about that. Think about how long we've been dosing thyroids, and we're going to talk about some of the ways to test thyroid function, okay? It is grandfathered from the FDA. The FDA does not like it, so the FDA is doing everything they can to stop it from being imported into the country and sourced into the country. I won't doubt if eventually, it is taken off the market. They make it so difficult, but we'll always be able to get T4 and T3, hopefully. Realize this is nothing new. When you think about products that the FDA tries to stop, so when we talk about FDA approval, Armour thyroid has never been FDA approved. We've used it for almost 100 years with very few problems. But realize that codeine has never been FDA approved. I don't know if you guys know that, but codeine has never been FDA approved because it was around way before the FDA was around, and the FDA doesn't like codeine, so they're really trying to take it off the market because it's never been proven safe and effective. Okay, keep that in mind. Okay, the thyroid glandulars, they're basically like what I was talking about with USP desiccated thyroid, porcine thyroid. They're ground up pig's thyroid. I talked about some of the issues with them. Here's some things that some people say that it's better because it contains T1, thyroid 1 iodine molecule, but we don't really know what that does necessarily, and it might have some benefits. That's one of the problems. One of the problems with when you try to isolate active ingredients from a natural product, you're trying to guess what the active ingredient is. So, aspirin's a perfect example. Aspirin is from white willow bark, okay? So white willow bark was used as tinctures and in teas forever to treat headaches and to treat fevers. And Bayer in the 1890s decided, well, wait a minute, we should patent this drug. We should find out what's active in there and patent this drug. And that was one of the first drugs ever patented, was aspirin. But what happens with aspirin? We get GI bleeds, we get tinnitus, we get all kinds of side effects. Never happened with white willow bark. So we don't know what's in some of the things that make it work, or make it work synergistically, or decrease some of the side effects. So that's one of the problems when you have any kind of natural product. Iodine, it does have iodine in it. Iodine's a good thing for thyroid. It does help the T4 to T3 conversion. Another problem with porcine thyroid is it's a foreign product. It's a porcine product. So there are certain patients that will react to it. Hashimoto's patients, it will sometimes make they will react to it and they don't respond very well. So their thyroiditis will get worse. Strict vegans, kosher patients, and it's not slow release. So that T3 is going to wear off in the early afternoon or late morning. Levothyroxine, isolated in 1914, synthesized 1927. This is when it really became standard therapy over porcine thyroid. I believe this is when Synthroid came out, so they started marketing it heavily. This was something that was kind of new to me when I started preparing for this presentation. I see a unique subset of patients because I see specialty type patients. So I usually see the patients that have not responded to levothyroxine, but I just really didn't realize that it was the most commonly prescribed drug in 2016. So that just tells you, You know, be looking, you see a lot of these patients, so be looking for patients that don't respond to T4 therapy. We're going to get into that. Here's one thing bad or good about T4 therapy. It's got a half-life of 4 to 6 days. So what does that mean? It means it lasts in the body a while, but that also means it takes a while to build up to steady state. That's why you can't just recheck T4 therapy. You can't recheck thyroid therapy after, you know, 2 or 3 weeks even. I like to be stable for 8 weeks before you recheck thyroid levels. And it is a standard therapy, and for most patients, levothyroxine does work because they do convert to T3. But think about the ones that fall through those cracks. Levothyroxine, much more potent. It's got a shorter half-life. It does not affect TSH. We'll get into some laboratory monitoring with thyroid here shortly. Immediate release, isolated 5053, approved for use in 1956. There are generics available. Okay, so with the more potent T4 to T3, we need to convert to T3 to really get the optimal results from thyroid. So this is what can happen if you don't have optimal thyroid function. You have that decreased conversion, and then you have it's interesting trivia. The results don't really, the treatment doesn't really change, but it's really cool to think about. There's some patients that will take T4 and they will convert it to reverse T3. I don't know if you've ever heard of reverse T3, but you can check reverse T3. It's super expensive, and you use it to send it out. And so I don't necessarily recommend it because the treatment is just T3 anyway. You give more T3. But reverse T3, this is very interesting. I mean, just think about some patients that have symptoms that are on levothyroxine and they still feel cold, and you know their heart rate's still low, and they just have low thyroid symptoms still. Reverse T3 is what is high in mammals during the winter when they hibernate. So bears and stuff in the winter have really high reverse T3. So think about that. When we have these patients that are on T4, levothyroxine, and they have all these low thyroid symptoms, their TSH might be better, their T4 might be okay, but if they're converting it to reverse T3, then they're going to feel like they're hibernating. And there are quite a few patients like that, so think about that. Increased binding. Thyroid binds with proteins in the blood, and when it binds with those proteins in the blood, it is not free. It is not free to work at receptor sites. So it's important to know a free level of thyroid. And the hormone might not be working at the receptor site. Hashimoto's, which is basically where the body's making immunities to thyroid. Some things that affect the conversion, nutrient deficiencies are very big. Iodine, the selenium. You know, I just recommend, you know, a good multi-mineral, a really good multi-mineral. And of course, vitamin D3, I don't know if I have a slide on this one in this presentation, but vitamin D3 affects thyroid function very much so. If there is one supplement your patients can take, it is vitamin D3. Everybody is low. Vitamin D3 is, you know, made in our skin in response to sunlight. So in the winter, we don't get it right. And even in the summer, what do we do when we're outside in the sun? What are we told to do? We're told to cover up. We're told to use sunscreen. That completely negates the production of vitamin D in our bodies. And even up here in northern latitudes, we don't get the direct sun rays. So everybody's low on vitamin D. And I think it's worth checking and make sure they're optimal. Make sure their level's over 60. Normal is not 31. I mean, it is normal, but it's not optimal. So make sure they're up to, over 60, and realize that a normal vitamin D, average vitamin D dose now to get patients to optimal is 4,000 to 6,000 units a day. Very important. So those patients say, "Oh, I take vitamin D. I take 1,000 units a day." Good for them, and you know, tell them that, but that's probably not enough. So you know, check them, and you know, let them know that okay. You know, double that dose or whatever. I think my microphone just went dead. Hello? Hello? Can you guys still hear me in the back?
Yeah.
Okay. I don't know if we're having a battery issue or what. I'll do my best. So, 4 to 6,000 units a day. Realize that vitamin D, vitamin D3 is the most important, not D2. The prescription D2 is kind of like thyroid T4 to T3. Vitamin D3, cholecalciferol, is the active vitamin D3, okay? It's the active vitamin D in our bodies. So the Replesta vitamin D2 that you prescribe, that is prescription, it's D2, it's not D3. So make sure you give them D3. It's over the counter, it's inexpensive. You can also dose it higher dose once a week because vitamin D3 does have a half-life of 19 days, so you can dose it once a week. Now remember, a lot of us, older people like myself, in pharmacy school, I learned that, oh yeah, vitamin D is a fat-soluble vitamin. You need to worry about overdosing on it because it can stay in your body too long, and the average, you don't need more than 400 units a day. I think we've completely debunked that. I think most of us realize that now, but that is totally, totally false. If you're out in the sun, naked sunbathing for 20 minutes, you produce 25 to 30,000 units of vitamin D. So to think that we can overdose on vitamin D at 5 to 10,000 units a day is pretty crazy. I talk about vitamin D because it's so important with thyroid and many other things. It's more than just for bone health. There's many other things. Some things that increase binding: estrogens, birth control pills, prednisone. Think about those. Those will increase binding and the thyroid won't work as well. So it's important to check free levels. Some of the things that might not be so obvious, but as we age, a lot of hormone-related issues are just get kind of worse. Alcohol, stress, cortisol. You think about that, that makes sense. Cortisol is kind of like a corticosteroid, so it's going to increase binding.
I think your microphone may have just went out.
Yeah, it did. So we're probably not getting anything on video if you can't hear me on audio.
They probably are here.
Oh, they are. We got an external mic. All right, we got a room mic here. So the audience has to engage so they can hear us. They can hear you guys laugh.
So long, it's like a
That's right.
mouse.
All right. This is probably going to be the biggest paradigm shift for you guys in this presentation, is the history of thyroid testing. So remember I talked about when the glandulars started out in the 1890s. We're just going to change my shooting battery.
I think battery's just as fast. That's what's going on. It would be the easy solution, but your life is still on. Who knows?
But they start dropping signal like that.
Yeah, they just do that.
Who wants to test this on their tongue to see if the battery's bad?
Did you say something?
Test. Much better.
Yay, team. Throw this away so we don't use it again. Thank you.
All right, so back to testing. Yeah, that's much better. So the history. Remember when the thyroids, the different thyroids came out, glandulars in the 1890s, and then levothyroxine early in the 1900s, but really became standard practice in the 1960s. So realize there's some history of thyroid testing. We used to check iodine years ago. That's how we checked thyroid, to see if they had good thyroid function. There's still some providers that do that, and there's what's called a thyroid pain test or an iodine pain test. I don't know if you guys ever heard of that. It is interesting, and maybe it's another tool. But here again with testing, and I don't care what test it is. But one of my professors in pharmacy school years ago, I learned so much from him because he said tests are a tool to go along with symptoms and history. And that's not just thyroid, that's cholesterol, that's all hormones, that's everything. They're a tool to go along with symptoms and history. So think about that. Iodine testing, TSH, I don't remember the exact year, I don't know if I have a slide in here about it, but we realized it wasn't really a good test, so then we did a more sensitive TSH that came out in the 1970s, symptoms and history, and now remember this, I got a great story to tell you. So I was born in 1970, Little Rural Hospital in Othello, Washington. I had a great doctor named Richard Bunch that delivered me and my twin brother. And I was doing a thyroid presentation probably 15 years ago in Othello, and Dr. Bunch was still practicing. He retired just a few years ago. Amazing. His son is still practicing medicine. Some of you guys might know him. So I'm doing this presentation and I'm talking about the different ways to test thyroid. And they're just like, well, wait a minute, the gold standard is TSH, and that's what we've been taught. That's what the endocrinologists say. I mean, we just have to use TSH. We have to use TSH. It's just, you know. I said, hey, Dr. Bunch, back in 1962 when you started practicing medicine, because thyroids were around, right? We already had thyroid drugs. I said, how did you test for thyroid? Well, we didn't have fancy labs back then. So we palpated their thyroid. That's quite a concept. Think about that. Wow. Well, we actually touched the patient. And we, you know, we did symptoms and history, and we gave them a trial of thyroid. Usually, I think they would give Armour thyroid because it was just more popular then. And we would give them a trial of thyroid, and if they did better, we would keep them on it. If they did better but not quite good enough, we'd give them more. So you guys get the picture here? I mean, tests are a tool to go along with symptoms and history. And I think in medicine we use it. I think they're good if we know how to interpret them appropriately and realize the limitations. So here's just some more testing. You know, total T4, total T3 in the 60s. The limitation of that is that you're checking bound thyroid, so it doesn't work at the receptor site. The first generation TSH, thyroid binding globulin. That is what allowed us when we did that. That's a protein. That was what allowed us to be able to test free T and free T4. Okay, TSH. Is TSH a thyroid hormone? Right, it's a pituitary hormone, right? Okay, let's go a little bit off track, all right? Who is used to prescribing and testing for testosterone therapy? What do we check when we put somebody on testosterone and we check their levels 8 weeks later? Do we check their FSH and LH? Not usually, not if it's primary hypogonadism. We check their testosterone level. You see what I'm getting at with TSH? It's a pituitary hormone, it's not a thyroid hormone. Doesn't it make more sense that we check their T4 and T3 level? Just think about that. TSH is a negative feedback loop, so of course, the lower the number, the higher it is. Your pituitary is telling your thyroid to make more thyroid. So the higher the number, the worse your thyroid is working. Here's one of the problems with TSH: is one missed dose can totally screw up a TSH. So compliance is a huge deal. So. When to consider replacing T3. So I think TSH might be a good screening tool. I just don't know if it's the best tool when we're monitoring thyroid function. So here's what we do a lot of is compounded thyroid. We can compound a T4 T3 combination. It kind of so it is porcine free. It doesn't have porcine in it. It's slow release. So it releases a T3 slower, kind of like how your body does it, more mimics your body, and it allows us to change that ratio, so you're not restricted to that T4, T3 ratio, which can be an issue sometimes. I talked a little bit about this, because I'm going to go into progesterone a little bit later. I'm not going to hit on this too much, but just realize that your adrenals trump everything, and if a patient's not sleeping, you need to make sure they're sleeping, because that's how they'll get better. I talked about vitamin D already. Testing thyroid function. So here's what I like to see. I like to see a free T3, free T4, and a TSH. And you say, well, why do you want a TSH? You don't really necessarily believe in TSH. Because if you don't do TSH and then they go to an endocrinologist, they'll call you crazy because you didn't check their TSH. So it is a gold standard, and it's just nice to have there. And don't be surprised sometimes if you dose thyroid optimally that the TSH is suppressed. TPO is more if they're Hashimoto's. It's your antibodies that you produce to thyroid. Reverse T3 I don't think is necessary most of the time. It's interesting though. And TSH is a good indicator of T4 levels only. So think about iodine. Too much, too little can be a problem. Realize that. Okay, any questions on thyroid? That is thyroid. I'm going to go into progesterone a little bit later. Questions on thyroid? Yes, ma'am.
Our patients are always in the hospital setting told to take their thyroid before the meal, like an hour, first thing in the morning. What is?
Yeah. So the question is, you didn't hear it. Patients are told to take their thyroid first thing in the morning. What's the deal with that, right? Mm-hmm. Okay. Here's the deal with that: is that thyroid is better absorbed on an empty stomach. Okay. whether it be T4 or whether it be T3, whether it be Armour, it is better absorbed on an empty stomach. So, but that doesn't mean they can take it with black coffee, they can take it with water, of course, and they can take it with most, I wouldn't say most. You gotta watch out for multivitamins and multiminerals. Split those up because they can, especially the minerals, can bind the thyroid up. So the more empty stomach, the better. You know, coffee with cream has been shown to decrease the absorption. Any kind of food can decrease the absorption. Here's the thing, and I've heard so many pharmacists tell patients this, and it just drives me nuts. I want to pull my hair out, okay? Patient's been taking thyroid for 10 years. They feel great. They're stabilized on thyroid. They've been doing the same thing for 10 years. And they say, yeah, I take it with breakfast every morning. Right before I eat, I take it with breakfast. And the pharmacist says, oh no, but you see, it says right here, you gotta take it on an empty stomach. Whoa, whoa, whoa. Yes, it is better absorbed on an empty stomach. But now all of a sudden, if you tell this patient to start taking this on an empty stomach, their levels are gonna go up, and then they might have side effects, and their labs are gonna be way off. Consistency. So if they've been taking it, and this is what you see in a hospital all the time, because hospitals have that black and white, yes, empty stomach, we're gonna take this on an empty stomach, although the patient hasn't been doing that at home. So in hospitals you'll see, that's why I'm not a big believer in hospitals changing a lot of that stuff. I mean, I guess you can change their dosing schedule because that's the way it works in the hospital, but go home with the same thing. And don't make a lot of big changes in the hospital if their thyroid function is off. You know, because just it's important to stay consistent. It's the same thing with, you know, warfarin therapy. When somebody says, oh, you've been eating spinach with your all the time, you're not supposed to do that. That's really not the truth. It's just be consistent with what you've been doing. Because now all of a sudden, if you don't eat that, it's going to throw your levels off. So does that help your question?
Yes.
Okay. Any other questions about thyroid? Yes, ma'am.
I was going to say, along that line, I get a lot of patients that go, well, I'm supposed to take my thyroid on the empty tummy, but then I'm on PPI.
Yeah.
How does that affect?
PPI is not going to affect absorption at all. You know, because there's no, it's more of a fatty things and minerals that can bind thyroid that are really going to decrease the absorption. Now, that being said, I mean, PPIs decrease the absorption of a lot of other nutrients, but it's not going to hurt. It's not going to hurt the thyroid necessarily. You had a piggyback on that question? Yes.
For people who work like innovative shifts, like night shifts, and then you have days off, when would be the time to take?
Wow, yeah, I mean, that's a great question. I will tell you, that's an 8-hour lecture right there about adrenal glands. And, you know, it's tough. And I can tell you I don't have a great answer. I think what's important is that they try to lead their life. And it depends on if they're working you know, it depends on their shift, their type of shift work. Are they working 7 days in a row, nights, and then they're off, and they're kind of trying to do a day schedule? That's, you know, but the closer you can be to being consistent and taking the same time every day is good. Obviously, if you work night shift, that's very, very, very difficult. And I mean, that's just a whole other story about how, you know, we deal with this all the time, I think, when we have, you know, night shift workers come into our office, and all of us in primary care would probably say this, is, you know, and their hormone levels are just crazy, and they haven't slept really that well in years. And, you know, let's face it, folks, our bodies are not meant to work nights. And I applaud people that do work nights, but when those patients are deteriorating, it's time to tell them, you know what, you need to think about a day shift. I mean, we are diurnal creatures. We are not nocturnal creatures. We are meant to work during the day and sleep at night. And my wife's mom worked, bless her heart, she worked to take care of her kids so they didn't have to be in daycare. She worked as a night nurse for years, and her sister was 10 years older than her, yet she looked like she was 30 years older than her. Osteoporotic, you know, from too much cortisol. Horrible. Anyway, that's a whole other story, but adrenal glands, think about that. If you're not sleeping at night because your cortisol is high, it is going to mess up your hormones totally. So, yes, ma'am.
Okay, you real quickly said something about how much sun converts into your vitamin D3. I didn't catch that.
Okay, the question was about vitamin D3. What was that?
You said something about how much sun converts into it.
Oh yeah, so if you sunbathe naked for like 20 minutes, you produce 20 to 30,000 units of vitamin D. So I like to use that. I like to use that trivia because when when people say that, oh, well, you're going to overdose on vitamin D because you're taking 5,000 units a day, I think that's just crazy. Any other questions? All right, so I'm just going to, the general term bioidentical hormones, we kind of hit it really quick, but bioidentical hormones, here's a list of some of them. Realize, I know bioidentical sometimes has a bad connotation because of, I think it's related to things that aren't FDA approved. But let's realize this. Estradiol is something you prescribe every day in your practice. Progesterone, testosterone, these are things, this is nothing new, folks. This is nothing new at all, okay? In fact, most all the stuff that I talk about, you can find in your Physiology 201 book, okay? Progesterone, what does progesterone mean? Back to Latin. Progesterone, what does it mean? Pro, support, or for, gestation, yes, hormone of pregnancy. Oldest known sex hormone, I think it was isolated in 1937, something like that. Present in every human regardless of age or gender. Yes, men have progesterone. Yes, it does have some benefits in men. Produced by the ovaries and some with the adrenals, secreted by the corpus luteum. After pregnancy, has receptors in almost every cell in the body. Why is that important? What do we learn in pharmacy school, nursing school, medical school? We learn that if you don't have a uterus, you don't need progesterone, right? And that's really interesting to me because it's the only magic hormone I know of that only works in one tissue in the body. Right? Think about that. Progesterone works like other hormones in all tissues of the body. So just because a woman doesn't have a uterus doesn't mean she doesn't need progesterone. I'll get into the politics of how that started. I hope I have time. Uterus, breast, brain, smooth muscle, metabolize other hormones, offsets effects of estrogen. That's why our bodies make it together. Progesterone. Okay, write this down. I already had you guys do this yesterday, but for people that weren't there, this is a very good reminder. I teach this every time I teach hormones, whether it's a pharmacy student or whether it's a doctor. Progesterone does not equal medroxyprogesterone acetate, okay? In my Goodman and Gilman 9th edition pharmacology book, they link these in the same category. But small differences in a molecule can make huge differences in the body. Progesterone, pregnancy hormone, right? What do we use Depo-Provera for? Birth control. Bingo. So when a doctor or somebody tells you that they're close to the same, just remind them that they act way different in the body, okay? And realize that testosterone and estradiol are pretty close to the same molecule too, but if you have enough testosterone, you'll be a man. So think about that. Small differences make a huge difference in the body. Progestins are synthetic, man-made molecules, and they're developed to try to mimic the actions of progesterone. Why did it come about? Why did progestins come about? Because in 1947, when Premarin was developed, Wyatt Ayres realized 10 years later that there was an increased risk of uterine cancer. That shouldn't really be a surprise to us because estradiol causes proliferation of uterine tissue, okay? It causes the endometrium to thicken. This is basic physiology, folks. Progesterone decreases that thickening. If you hear my presentation yesterday, it's kind of like fertilizer for the lawn and a lawn mower. The progesterone gets rid of the weeds in the lawn. So they couldn't patent progesterone because you can't patent a natural product. You can only patent a delivery device. So they came up with medroxyprogesterone acetate. Medroxyprogesterone acetate does decrease the risk of uterine cancer because it does work in the uterus somewhat like progesterone does. But it doesn't work in the breast tissue, it doesn't work in the bone tissue like progesterone. So they are different animals. So whenever you're reading a study, and believe me, there are so many of them out there, progesterone proven to not help for bone density. I'm just making one up, okay? Start reading it, and then they'll say, we used 10 milligrams of medroxyprogesterone acetate daily to show that it did not work for bone density. Just quit reading. And I'm serious, there are so many of those studies out there. And I get it from providers all the time. They're like, what do you think of this study? It says progesterone's bad. No, it says medroxyprogesterone's bad. They label it progesterone. It gets messed up all the time. All right. Our hormone cascade, I like talking about this. Cholesterol bad, right? Without cholesterol, we will die. It's important for every cell in the body, especially the brain. And most sex hormones, the backbone is cholesterol. And progesterone can be made into other hormones. I wish it was as easy as you could give pregnenolone and then all these would go into balance. It doesn't work that way because you have so many cofactors and different enzymatic reactions that happen there. Some of them, most of them we don't really know how. Okay, progesterone use is PMS, endometriosis, makes sense, right? I talked about how it worked on the uterine tissue to decrease proliferation of uterine tissue, endometriosis. They don't necessarily need a hysterectomy. Think about progesterone first. Fibrocystic breast, progesterone works in the breast tissue like it does in the uterine tissue, decreases cell proliferation. Are you guys getting on there? Are you guys thinking, are your wheels thinking now about why estradiol alone causes problems, whether it be increased risk of breast cancer, whether it be increased risk of uterine cancer? Because it's not given with progesterone, okay? There will never be a study, never ever will a drug company spend $1 billion to prove this, but this is basic physiology, okay? PCOS, irregular bleeding, luteal phase defect, anything that has to do with a cycle, anytime a woman comes to you and anytime her problem is cyclical, progesterone, progesterone, progesterone. Think about that. So here's some things that, okay, a WHI study normalizes blood clotting. It has an antithrombin effect, okay? Estradiol increases thrombus risk, right? We do know in 2002, the WHI study in 2002 showed, what did it show? It showed Premarin, which we've already talked about the disadvantage of Premarin. Premarin increased the risk of cardiovascular disease from thrombus formation. Okay, we shouldn't be surprised because what estrogen does. What if they were on progesterone? Not medroxyprogesterone acetate, but on progesterone. It normalizes blood clotting. What else did a second arm of WHI study show? It showed that Premarin plus medroxyprogesterone acetate increased the risk of cardiovascular events. Okay, we shouldn't really be surprised because medroxyprogesterone acetate does not normalize blood clotting. Progesterone does. Okay, that's all we can take away from the WHI study. It says nothing about estradiol and it says nothing about natural progesterone. Many, many women suffered for many, many years because of that and had a lot of symptoms because of it. Stimulates osteoblast production. Remember, estradiol decreases osteoclast, the breakdown of bone function. So progesterone increases osteoblast, the building of new bone. They work synergistically together in the bone. How about that? Our bodies make them together. I think they should be given together. Although if you want the best bone building hormone we have in our bodies, testosterone. Testosterone for osteoporosis. Men get osteoporosis also. It's not from lack of progesterone, it's not from lack of estradiol. So obviously, those things some functions of progesterone benefits, balance the effects of estrogen. You know, one of the things estrogen does, holds water. Progesterone acts as a natural diuretic. Think about some of these symptoms that too much estrogen can cause. And remember, usually when a woman is perimenopause, her estrogen levels are fine. If you check their estrogen levels are fine. Their cycles are becoming more irregular. They're making enough estrogen. They're not making enough progesterone. Think about progesterone in those women that are perimenopausal, or PMS, or premenopause. Progesterone is so important. Uterine fibroids. On our show in a couple weeks, I have a radio show that we talk about everything healthcare. I have a gal that my wife experienced uterine fibroids too, and of course they want to do a hysterectomy. Progesterone. Uterine fibroids are caused from too much estradiol and not enough progesterone. And so think about that before surgery. I have a gal on my radio show that she had a pregnancy, in her first pregnancy, and they want to do surgery after her uterine fibroids, and she did some of her own research and found out that it was hormone related and her uterine fibroids are shrinking. So think about that before surgery. Surgery is a very, it can't be taken back. Progesterone osteoporosis, because it does increase bone density. Medroxyprogesterone acetate does not have that same function. Remember that. Side effect profile, oral progesterone, slight to moderate drowsiness. There is one, if you dose it too much, they'll have a feeling, because it does prepare breast for lactation, they'll have a feeling of breast fullness. You don't see that except in pretty high doses. And look at the side effect profile of medroxyprogesterone acetate. Okay, so what's important with hormone replacement, whether it be just progesterone or whether it be hormones in general, is every patient is different. So know how to test and know how to interpret tests. There are some different ways to test. You may have heard of blood versus saliva. There's a lot of debate there. I could argue both sides. Blood is most common, serum, so it's easier for most providers to relate to. Saliva has some benefits. It's actual tissue levels. So, because think about it, I make an analogy like this with antibiotics. So, with antibiotics we have an MIC, minimum inhibitory concentration of an antibiotic, right? And it's like, okay, well, the minimum inhibitory concentration of let's just make one up, sulfamethoxazole for a urinary tract infection is XYZ in the blood, okay? Well, why do we care if that drug never makes it to the kidneys? Because if it doesn't make it to the kidneys and concentrate in the kidneys, then it's not going to work very well for UTI, right? So same thing with pneumonia. If you've got a drug that is high in the blood, but it doesn't penetrate into the lungs, it's not going to work. So that's why I like saliva level, because it may be more representative of tissue level. And definitely for saliva, if you're testing cortisol, talking about our night shift workers or many patients for that matter, if you want to do a 4-a-day cortisol level, saliva is obviously much more convenient than blood draws. But like with all testing, it's a tool to go along with symptoms and history. Now, the toughest time to test a woman is before she's in menopause. Why? Because her levels are all over, especially if their cycles are irregular. You can say, well, do it on days 19 to 21. Okay, well, I haven't cycled in 2 months, and then they cycle, and then, so they're a tool to go along with symptoms and history, especially when they're still cycling. So, in blood versus saliva, obviously with saliva, if you're doing sublingual dosing, you're going to get super, super high levels, so you got to be careful with that. Here's what I would order if you're testing hormones in general: progesterone, testosterone, free level. We don't have time to talk about that, but it's the same thing as thyroid: estradiol, DHEAS, cortisol, and a complete thyroid T4, T3, free T4, free T3, and TSH. Cortisol, if you can do it 4 times throughout the day, it's optimal, but maybe just a morning only. Oral dosage forms. I like oral dosage forms, especially progesterone. If taken at night, it converts to 5-allopurinol, which helps to induce sleep, lower cortisol levels. It works great. Some women say they sleep better the first night. Oral progesterone is amazing. The problem with the commercial available product that contains peanut oil. Why a drug company would put peanut oil in their formulation, I have no idea. Why didn't they use mineral oil or cottonseed oil? Unbelievable to me sometimes. And it's immediate release, so it doesn't last all night long, like how your progesterone would be made in your body. So a slow release formulation does work better. Topical, hormones are absorbed great topically, all hormones, including progesterone. I've actually done a study, a published study. I did it with my twin brother, who's an analytical chemist, and we published a study to show the absorption of testosterone over time, and at 1 hour post, 2 hours, 6 hours, even 12 and 24, but we didn't publish that data. And it just shows that the even curve you can get with topical administration of hormones. If you want more information on that, I can get it to you. Sublingual, buccal, that's inside of the mouth, under the tongue. Hormones are absorbed well that way. Disadvantages, they don't taste great necessarily, especially in the higher doses. And the disadvantage is you do swallow some. That's not always bad necessarily, but you kind of get the best of both worlds with topical and buccal, because one of the problems with oral administration can be the first pass effect. I think there's some erroneous information in the first pass effect, in that some doctors will say, well, I like topical progesterone or whatever because it doesn't go to the liver. Let's remember this. Now, first pass effect is when you swallow something, it is going to go to the liver first. And actually, the first pass effect also has to do with the gastrointestinal tract breaking the drug down too, not just the liver. But it is going to be absorbed into the liver first thing. But any drug that gets into the blood is going to eventually go into the liver and be metabolized. That's what our liver does. So don't ever think that a drug is going to bypass the liver. That's a big problem, because it's not going to. Our liver is made to detoxify many different things, including drugs. Vaginal administration, oh my gosh, vaginal administration, great absorption. Obviously mucous membrane, good blood flow. There's many drugs, including testosterone, estradiol, estrogens. This is our #1 prescription right here that we make up, estriol vaginal cream. I believe every postmenopausal woman should be on an estrogen vaginal cream. Lots of local benefits, decreases UTIs, decreases bladder urinary incontinence, atrophic vaginitis, painful intercourse. The list goes on. And if they're not on it, they will eventually get urinary incontinence, they will eventually get UTIs, you'll see them in nursing homes. They don't lack those drugs, they lack estrogen. So vaginal is not only does it work systemically, it is absorbed systemically, but it has local effects too. All right, that was fast. Yes, ma'am.
What's the coverage on that insurance?
Coverage on what?
On the
Estriol?
Yes.
Oh, that's the beauty of it. That's a great question. So, at our pharmacy, this is kind of the commercial part of it, okay? I apologize. Close your ears if you don't want to hear it. But we don't bill any insurance. And one of the reasons we don't is because it makes everything more expensive. So our estriol vaginal cream for a 3-month supply, actually a 5-month supply, is $69. No prior authorization, no paperwork to fill out, no third-tier copay, no surprises for you when no surprise calls from us saying, hey, this is $350 because it wasn't covered, or this is a $150 copay because it's third-tier copay. None of that whatsoever. That's our most popular drug. We ship it all over the Pacific Northwest. Urologists and gynecologists all over prescribe it for those reasons. Another question? Yes? You have your hand up? No? Yes?
No.
No? Okay. Any other questions?
No, I was just telling my colleague over here that when I was in school, we did a rotation in Hawaii, and functional medicine is really big over there.
Yeah.
And the supplements like DHEA, for example, were very popular.
Yeah. I'm a big believer, if you check out our radio show, we've had a couple providers on there that are functional medicine providers. The question was, she was from Hawaii, or the comment was, she was from Hawaii, and functional medicine is big there. We've had some providers on our radio show that functional medicine, and I'm a big believer in functional medicine. When you think about what we do every day in our healthcare, we are putting out fires constantly. Oh, you have high blood pressure. Let's prescribe you lisinopril. Well, what's causing high blood pressure? Why don't we get to the bottom of that? Why don't we change that problem instead of just treating a symptom? So I love functional medicine. I personally think hormone replacement is probably the first functional medicine, probably the first and maybe most important. I know there's that can be a big argument. That's my passion, and that's what we do a lot of. But hormone replacement is definitely functional medicine. We talked about levothyroxine being T4 because it had 4 iodines. Levothyroxine is T3. Why? It has 3 iodines. Let's remember that T3 is the active form of thyroid. I don't like to call it active form of thyroid. It is just a more potent form of thyroid. So levothyroxine might not work for everybody, okay? Even though it's the #1 prescribed drug, and it probably works for 90% of patients, if they are not converting T4 to T3, they will not feel good. Their TSH will go down. Their T4 will go up, but their TSH will not go down. They won't feel good, and their T3 is probably low. So some of the factors that change that: nutrient deficiencies, iodine deficiencies, selenium. Don't forget about medicines, including birth control, that will decrease thyroid function. I'm not going to go too much into it because I want to focus on case studies. So make sure with thyroid, make sure you're testing. It's not just TSH you want to check. I know it's the gold standard, and I know that's what we've always been doing. But realize that free T3 is the active form of thyroid, and it's probably the most important. And I know there's a big debate about that, but is TSH thyroid? Is TSH a thyroid hormone? Interactive portion of the class here. Is TSH a thyroid hormone? It's a pituitary hormone, right? So when we monitor testosterone therapy, what do we test in their blood? We don't check FH or LSH, do we? Or FSH or LH, do we? We check testosterone, right? So that's kind of what I'm saying about thyroid, is that we should check, T4 and T3 levels, and TSH. I get it because it's gold standard, but realize that you need a complete panel. You need the complete picture. So I recommend all of those, and labs are a tool to go along with symptoms and history. So let's treat to effect. I have a story. I'll make it quick. And thyroid's been out since the 1930s, but we haven't had testing since like the 1960s or 70s. So there was a time where we didn't have a way to test thyroid, and there were doctors that gave thyroid. before we had a test, and they would just do it by symptoms and history and, you know, palpation of their thyroid. I did a thyroid presentation in my hometown of Othello, Washington, and the doctor that delivered me was there, and these people were asking questions about it. I said about, well, you know, TSH is the gold standard. I'm like, hey, Dr. Bunch, 1962, you started practicing, you prescribed thyroid? And he's like, yeah. I'm like, how did you test it? He goes, we didn't have any labs, so we gave him some thyroid, we saw how they did better, then we kept on thyroid. So realize, tests are a tool to go along with symptoms and history. So thyroid, I talked about levothyroxine. Cytomel is T3, it's not sustained release. Armour thyroid comes from pigs. It's kind of like Premarin. It's the only commercially available product that we have that has T3 in it, though, that has a mixture of T3 and T4. Cytomel is separate, but it's short acting. So is Armour thyroid. I hit vitamin D because if there's one supplement patients can take, vitamin D is it. Everybody's low up here in northern latitudes, even in the summer, because we use sunscreen. So these are all the things that vitamin D can treat, and it helps for thyroid function. So testing hormones. Female, estradiol, progesterone, testosterone, DHEA, and cortisol. Diurnal cortisol 4 times throughout the day if you can. That's pretty tough with blood. But free T4, free T3, TSH, vitamin D. Really, we don't have much different with the males, except we don't do progesterone necessarily, although we can. And estradiol, should we test estradiol in males? Absolutely we should. Testosterone can convert to estradiol through aromatase. We should know what their estradiol is. All right. Are you guys ready for case studies? All right, you guys ready to change the world with these case studies? All right. You guys still awake?
Yes.
All right. So, patient MJ, 42-year-old with cyclical migraines. Here's what I ask you to look. Cyclical migraines. Anytime anything follows a woman's cycle, think progesterone, 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 progesterone. Okay? I'm going to guess, do you agree that this gal does not have an Emitrex deficiency? You're supposed to laugh there. Okay, right? She probably doesn't, right? More common than not, I mean, a lot of times these are cyclical stuff is progesterone related. That's what causes us to cycle, okay? But look at some other issues too. You know, she had a history of car accident, pain, fluoxetine for depression. I want to tell you, so I guess the purpose of the slide is anytime something follows a cycle, think progesterone. Think progesterone, progesterone. And we'll go into some dosing with it later. So check her hormones. I mean, you know, all the hormones are probably good. So, patient in M, 49-year-old female with recent diagnosis of fibromyalgia. Okay, fibromyalgia, that's another thing. When you see that diagnosis, fibromyalgia or chronic fatigue, something like that, you know, in a female that's that age, and you ask them, well, when did this start? Oh, it started a couple years ago. My cycles became irregular. Oh, bingo. Okay, so this happens all the time. So think hormones. Gained 15 pounds the last year, hair is thinning, decreased libido, decreased energy. Realize decreased energy, decreased libido, symptoms of low testosterone and low thyroid. That's why you have to check them both. Depression, recently started citalopram. Recent diagnosis of high cholesterol, started atorvastatin. Feeling aches and pains, especially around the neck and shoulder, taking hydrocodone and gabapentin. Okay, check hormones. Patient is already taking levothyroxine 0.1 milligram. Hormone levels come back. Remember the hormones we talked about testing? I did not put units in here. Units aren't that important necessarily, especially for this presentation. It's just important to know ranges, okay? Because every lab has a little bit different numbers, and realize that these ranges are big. So 15 to 70, testosterone, she's a 17, TSH, 2.9, normal is 2 to 5, free T4 1.5, that's not a surprise. She's on the higher end of normal on that because she's taking levothyroxine. Free T3, lower end of normal. So my first thing I'm thinking she's probably not converting this to free, she might not be converting this to free T3. Looks like she's probably not. This is total testosterone, not free testosterone. That's important also because free testosterone is what works the receptor site. Total testosterone is bound to sex hormone binding globulin and is bound up 90% sometimes or more. So you gotta know what the free level is. Well, look at her free level. Her free level is actually less than normal. Total testosterone versus free testosterone, very different numbers. Okay, that's why you gotta check both. So low thyroid testosterone levels mimic each other. I talked about that. I talked about the complete thyroid panel treatment. Testosterone 2 milligram cream once daily vaginally. Why do we apply vaginally? hormones are absorbed, and any drug for that matter, is absorbed great vaginally. Why? Mucous membrane, good blood flow, thin skin, bypasses first pass. It's amazing how hormones work vaginally. There are some studies to show out there that they're not, and I won't go to that for the purpose of this lecture, but they're absorbed great vaginally. I also like testosterone locally on vaginal tissue. There is not a better drug for vaginal atrophy than testosterone. Think about it. Testosterone's an anabolic hormone. What would be better for atrophy? Add some T3. She's already on the right dose of T4. So why not just add some T3, do it in a sustained release capsule, because T3 is short acting. You want it to last longer than 3 to 4 hours, so this will last all day, most of the day. Recheck these levels. Think about DHEA. Her DHEA is probably low, since her other hormones are. DHEA is an adrenal hormone, helps us to respond to stress. It does convert somewhat to testosterone in higher doses. Progesterone. Helps support sleep, normalize cortisol, night sweats. Okay, so first and foremost, if they're not sleeping, we gotta get them sleeping. Okay, so they're having any kind of vasomotor symptoms or they're not sleeping, we gotta get them sleeping. Progesterone helps to normalize cortisol at night, it is metabolized to 5-allopregnanolone when taken orally, which can cause slight to moderate drowsiness. And it does work for night sweats somewhat too, but if you're not sleeping, nothing is gonna get better. Remember, we will die without sleep before we'll die without food. Think about that. We can live like 3 days without sleep. We can live 3 weeks without food. Sleep is more important than food. Okay, 8 weeks come back. Free testosterone up to 5.1, a little bit high. Free T3 up to 4.6, a little bit high. Free T4, 1.5, TSH 0.25. TSH came down. T4 didn't move much. That's pretty common. Okay, a little bit high. All right, let's not get freaked out. Oh my gosh, normal is up to 5 and she's at 5.1. Oh, she's on way too much testosterone. We gotta decrease her testosterone. Realize labs are a tool to go along with symptoms and history. Don't freak out about it. Ask her how she's doing. Does she have any oily skin? Does she have any acne? No, I feel great. Okay, if you don't like that number, test like 5 hours later and it'll be down into the 4s. Realize that labs are a snapshot in time, and a small snapshot in time for that matter, which means, all that means is that's what their blood was at that time. So don't get too freaked out with a little bit of high T3 or a little bit of high T4 or a little bit of testosterone if they're not having symptoms. Realize if it's 1 hour post, if they took that blood draw 1 hour post dosing, it might be a little bit high, but 6 hours later it's not going to be. So that's why it's important to know the timing of the dose, the half-life of the drug, know how to interpret the labs appropriately. Feels much better, increased libido, cholesterol is lower, pain levels decrease. Testosterone is one of the best drugs around to help us respond to pain. It works amazing. Losing weight, more energy. Okay, some question marks here. Remember, she was on atorvastatin. Stop atorvastatin. Is atorvastatin causing the pain? I mean, I've known many of people, it causes rhabdomyolysis and it can increase liver enzymes. I'm not a big fan of statins. Realize that it itself can cause the pain. So think about stopping her atorvastatin. Citalopram, remember she had decreased libido. Is that one of the drugs causing that side effect? Now that her testosterone's up and she's feeling better, does she need that? Sometimes they gotta be on this for like 6 months. Sometimes before you can stop it. The atorvastatin can go away a lot sooner sometimes. But there's 2 drugs that we can stop right away. Treat the problems, not the symptom. Remember, her cholesterol wasn't high because she had a lack of atorvastatin. It might have been high because, obviously it could have been diet and lifestyle related, but testosterone helps to lower cholesterol, so does thyroid. So treat the problems, not the symptoms. We are so good today in medicine at just treating symptoms and writing for a new drug. Let's treat the problem. What caused the problem? Why did she have depression? Well, we know testosterone and thyroid both help to battle depression. So why would we want to balance her hormones while we're giving her a drug for depression? And that goes the same, I mentioned it with Effexor, but I mean, to prescribe Effexor for hot flashes, and now there's another fancy one coming on the market, makes no sense for me whatsoever. They do not lack Effexor. And I don't know if you guys have had experience of trying to get women off Effexor. It's like getting off crack. It is very, very difficult, and you have to titrate very slowly. So interpret labs appropriately, order the correct labs, optimal levels, not just normal. What's normal and optimal are 2 different things, okay? And think about the range, like TSH for instance. You know, the range of TSH is 0.5 to 5. So if a woman has, or man, has low symptoms of thyroid, and their TSH is 4.9, they're normal. But what were they when they were 40? And if they're not feeling normal, why don't we think about what would be optimal for them? LD, this is a very common, number one prescription that our pharmacy makes up is a cream to prevent, it's an estrogen vaginal cream. 55 years old, UTIs recurring, ER visits for 1 year. History of urinary incontinence, vaginal dryness causing painful intercourse and marital issues. Total hysterectomy at 49 years old due to uterine fibroids. Are you seeing some of these patterns? Symptoms started after stopping HRT 1 year ago because she heard it was dangerous to take over 5 years. So just what is this going on right here? So history of urinary incontinence, 55 years old. Do women in their 30s get urinary incontinence? Not usually, right? So what are these women lacking? They're lacking estrogen. They're not lacking ditropan. They're not lacking that. Usually their vaginal dryness starts a little bit earlier. That's the first complaint they have. That will usually start even before menopause sometimes, or right after. She went through non-natural menopause with a hysterectomy, but that usually comes first, and then UTIs and urinary incontinence follow later. How many women are in a nursing home with chronic urinary incontinence and UTIs? And so symptoms started after stopping HRT because it's bad. It's dangerous to take over 5 years. Nitrofurantoin for UTI, causing all kinds of symptoms, problems, not yet alone, resistance. Oxybutylene daily for urinary incontinence, causing drowsiness, dry mouth, all those symptoms. Family practice doctor, this is one thing that we see, and this is just unbelievable to me. Talk about treating problems, symptoms and not problems. Painful intercourse, right? So what does the family practice doctor prescribe? Lidocaine gel? I mean, come on. That's not going to be very fun for that woman, is it? Or her husband. Fix the problem. She lacks estrogen, okay? So family doctor referred to a urologist. Urologist prescribed estradiol vaginal cream, and you could insert permanent vaginal cream here too, and it was not covered under her insurance and was over $300. And we see that so often with the commercially available vaginal creams. The urologist then prescribed estradiol vaginal cream, and follow up in 8 weeks, vaginal dryness better, cleared up in 1 week, UTIs cleared up in 4 weeks. So stopped your nitrofurantoin, 6 months later, urinary incontinence gone. It's amazing what estrogen vaginal cream can do for, not only the outer appearance, but all types of stuff in the vaginal area. How long should you use estradiol vaginal cream?
Definitely.
We get that question all the time. And a couple months ago, I counseled a woman. She says, I was following up with her on her estrogen cream, and over the past 2 years, we've been giving it to her. And it stopped her UTIs, it stopped her urinary incontinence. And she followed up the urologist, and the urologist says, well, you're all clear now. She's in her 80s. You don't need this anymore. Think about that. She's not going to magically start producing her own estrogen. How long would we give her ditropan if she had urinary incontinence? Indefinitely, right? Right? So why wouldn't we give her estradiol vaginal cream indefinitely? Unless they want symptoms to come back. Unfortunately, I didn't know that doctor well enough to actually say, I think you should keep her on this. And I didn't want to get into a debate with the patient because I didn't want to get in between her and her doctor on that. If I knew the doctor well enough, I would say, look, so unfortunately she'll probably be back. Patient claiming depression, female, following cycles, remember progesterone hormones, muscle aches all over. This is a fibromyalgia patient, basically. Depression medication, cholesterol, sleep medication, venlafaxine for hot flashes, Fosamax for bone density. So I'm going to go over these really quick because I know you guys want to get out of here. But the point of this is kind of the same thing. Patient sees hormone specialist. Here's some dosing specific stuff. Progesterone, 200 milligram. It's going to help her sleep. Take it at bedtime. Oral 200 milligram. A sustained release capsule. Peanut oil free. Commercially available one has peanut oil in it, and it's not sustained release, so it wears off at night. Bias, we talked about that earlier in the morning. I believe in a sustained release capsule because if you think about how we make our hormones, we don't make them all at once in the morning or all at once at night, so slow release is better. That topical testosterone vaginally, and then a T4, T3 combination in a sustained release capsule. Look at her labs. Her labs resolved. It came up. Cholesterol lower, insomnia better, depression resolved, hot flashes gone. I love it when their first goal is to get rid of hot flashes because that is super, super easy. I mean, hot flashes should be gone in 7 days. So obviously, for hot flashes to go away and she starts sleeping better, everything is going to get better. Everything is going to get better. Bone density. Check bone density in 1 year. You know, this woman, we could possibly get rid of 5 medications just by balancing her hormones. Not only do we get rid of those symptoms that she had, but there's a lot of other benefits that we talked about earlier from hormone replacement. All right, let's get into the males. Sometimes we get forgot about, but I will tell you that when we first started this, my wife and I, 98% of our patients were male or female, and now about 50% of them are probably male, maybe even more. Very important. Look at some of these disease states. 52-year-old male, erectile dysfunction. So what do? We don't check their testosterone. We give them Viagra. Weight gain around the middle, depression. We give them Prozac. Decreased libido, increased cholesterol. We give them atorvastatin. So here's the drugs we put them on. Think about this. Common, very, 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 very common. Think about anytime they're on, these have symptoms like this. Think about their testosterone levels, hormone levels in general, for that matter. So this is kind of the same story as a woman, just different numbers. Total testosterone levels 250, 160 to 726 is normal. Oh, well, he has a normal testosterone. Well, yeah, but he's got all these symptoms, okay? So what's normal, what's optimal is 2 different things. I was fortunate enough, and everybody should test their hormones early so we know what people should be in their baseline. My baseline testosterone when I was 39 years old was 1250. So if I went to the doctor and I checked my hormones when I was 39, would they have freaked out and said, your testosterone's too high? Well, I'm not on testosterone. So realize that these numbers are ranges at that, and big ranges. So think about that. Testosterone, 100 milligram topical applied BID, scrotally. Scrotal absorption is great. Scrotal absorption, the scrotal skin is thin there. It's great blood flow, thin skin, less risk of transfer than if they applied it on their upper arm and shoulder. I produced a study along with my twin brother, who's an analytical chemist, and we published a study on 200 milligrams of testosterone applied once daily in the morning, scrotally, and it gets great absorption and delivers great levels of testosterone over time. Our study published was up to 6 hours, but we have data on 12 and 24 that we haven't published yet. The skin is a great delivery method for hormones, and why is that? The skin is a barrier, that's a good thing, right? The skin keeps us from absorbing poisons. All right? So what that also means is it is not going to allow anything to be absorbed too much too quick. So one thing about topical delivery of hormones is you don't get those high peaks like you would with injections. Injections, you get a high peak. I don't care if you're doing twice a week injections or once a month injections. You still get a peak right after injection. It's an injection. Think about it. It's going to bypass the safety mechanisms that we have in our skin. So we can not only use our skin to protect us from those high peaks, but also, because testosterone has a short half-life, when it's on our skin, it can be delivered over time, kind of in a depot effect. So that's what our study does show. If you want more on that, I can get you that. DHEA 100 milligram. Of course, look at these doses. They're bigger than they're higher than what a female would have. 2-week report, feeling less depressed, more energy, libido is increased, erectile dysfunction resolved, waking up with morning erections again for the first time in many years, can work out in gym again, wife calls the doctor to report great results. We see this all the time. And a lot of times the wife has to get their husband to go in. Many times when you balance a woman's hormones, you ask them about their husband, say, how's your husband doing? They're like, not very good. I'm like, well, give it 8 weeks because you're going to be ready to go and he's not. And then so it's important to get his hormones balanced. Think about when testing, timing of dose, half-life testosterone. I had a doctor call once, and this guy was 80-some years old, and he was on testosterone. He's doing great. Doctor called me and says, his testosterone is 850. That's way too high for an 80-some-year-old. I'm like, how's he feel? Oh, he feels great. He feels the best he's felt in years. Okay. I mean, high for what? Too high for what? I mean, it's not too high for a 45-year-old. It's too high for an 85-year-old that he's doing good. And when do we decide that we don't want to feel good? I mean, I don't know. I came into this world fat, bald, and peeing my pants. I'm not going out that way. Any symptoms of oily skin or acne? So in the future, we can think about as thyroid. With men, the first thing, the best benefit for the buck, as you can imagine, is testosterone. That's what makes us men. That's the first thing. Thyroid later on, when you want to optimize stuff, absolutely. 6 months later, this is a very, very common case. 6 months later, lost 20 pounds, hypertension's resolved, discontinue lisinopril. And you know what? I think that might. I don't have that last slide. Oh yeah. People have to figure. That's my presentation. So, do you guys have any questions? I will have questions. No questions? Come on. All right. I'm going to speak again tomorrow, but I need a topic. Would you guys like to hear more about thyroid? More about testosterone? More about estrogens? More about progesterone? What would you like to hear more about? Come on. Which one?
Thyroid.
Thyroid. Progesterone. Any others? All right, thyroid is first. All right, I can maybe mention something about progesterone. Thank you for being so attentive. Thank you for being here today. It was an honor to speak today. Thank you so much.